Hi Nicole, my name is Kimberly. I'm your student physical therapist. I'm going to be palpating some structures on you today. Is it okay if I am touching your hips and your legs and your arms and your back?
Yep.
Okay. So can I roll your shirt up?
Uh-huh.
First of all, I'm going to be palpating the liver. So I'll come off of this right thoracic cage, roll off of it inferiorly and apply pressure. Go ahead and breathe for me. And the liver is a good site to palpate because it'll let you know if the patient should be referred to a different provider or if the pain they're experiencing is something other than musculoskeletal. Next, we'll palpate the ASIS, so we'll come in on the iliac crest and follow them anteriorly. And the ASIS is the insertion point for your sartorius and the inguinal ligament. Next, we'll move on to the medial femoral triangle. So the inguinal ligament, you can palpate the pubic tubercle and find that, and that is the superior border from the inguinal ligament to the ASIS. We found the sartorius. It runs from the ASIS down to the pes anserine. And then if you put the patient in figure 4 and adduct, you'll see the adductor longus pop out, and that is the lateral border, or the medial border, excuse me. And the medial femoral triangle is a good landmark for finding your femoral nerve as well as your femoral artery. Next, we will have you come and sit on the edge of the bed. We will palpate the knee joint line, so you can find the patella and find the edges, the borders of the patella, and move into that soft tissue space and find the joint line. And then when the joint line kicks you out, that's how you know that you found the medial collateral ligament or the lateral collateral ligament. It's also a location where you can find the menisci. Next, we'll find the fibular head, so we'll palpate for the lateral epicondyle and move just distally. And then find that bony protuberance. And this is the insertion site for your fibularis longus muscle. And then the fibular nerve runs just inferior to this fibular head. And next, we'll palpate for the talus. So we'll move just down the tibia and then roll off the end of the tibia and roll onto the talus. The talus is important because it articulates with the fibula to create the talocrural joint, which is the main site of dorsiflexion and plantar flexion in your foot. And it is also the insertion site for the anterior talofibular ligament. Next, we'll move on to the navicular bone, so just inferior and anterior to the medial malleolus is this bony protuberance. It's the navicular tuberosity. This is an important site because it's the insertion site for your spring ligament, as well as your posterior tibialis muscle. Next, we'll move on to the base of the fifth metatarsal. It's the bony protuberance on the side of the foot, and this is the insertion site for your abductor digiti minimi, as well as a common site for a avulsion fracture from ankle sprain. And finally, if we move the patient into slight plantar flexion as well as inversion, we can palpate the anterior talofibular ligament. And this is it's the most common ligament sprain during an ankle sprain. And it can also help you find the sinus tarsi, which is one of its insertion points. And then we'll move up to the shoulder. So first we're going to palpate for the acromioclavicular joint. So we'll find the clavicle and palpate to the distal end where you fall off onto the acromion process, and that's where the acromioclavicular joint is. And this is an important joint because it's the site of shoulder separation if you fall on your shoulder, and it's also the articulation that holds the upper extremity to the trunk. And then if you just roll off that acromion process, you'll roll into the subacromial space. And this is a site where some of the tendons from the rotator cuff muscle run underneath, as well as the site of the subacromial bursa, which can be the site of bursitis and cause some irritation. And if we just follow the chromium process posteriorly, it'll become the scapular spine. The scapular spine is important because it's the landmark between the supraspinatus muscle and the infraspinatus muscle, and it also lines up with the T3 vertebrae. And then if we follow the scapular spine to the medial border of the scapula, and then we can follow the medial border down to the inferior angle of the scapula, and that is the insertion point for the teres major muscle, as well as it lines up with your T7 vertebrae. And then we'll have you come back around, and we'll do greater tuberosity. So you just roll on the anterior lateral part of the shoulder. You'll feel a bony protrusion. That is the insertion site for your supraspinatus muscle, and it also is the lateral border of the bicipital groove, and it can help you find the biceps tendon running near it. Then we will find the coracoid process. So we'll palpate for the concavity in the clavicle, and then just move inferior to it and push deeply, and you'll run into it. And this is the site of the attachment of the coracobrachialis muscle, as well as the short head of the biceps. And then we'll move down the arm, palpate down the lateral shaft of the humerus, and you'll run into the lateral epicondyle. This is the insertion site for the forearm extensors, as well as the insertion site for your lateral collateral ligament. We can do the same thing medially, palpate down the medial shaft of the humerus, and you'll run into the medial epicondyle, which is the insertion site for your forearm flexors. And if you roll right off that medial epicondyle towards the olecranon process, that's where the ulnar nerve runs, right in that ulnar nerve sulcus. Back to the lateral epicondyle, if you palpate just distally while the patient is in extension, you'll hit the radial head. That's an important site because it is near the radial tuberosity where your biceps tendon attaches, and it's also a common site of radial dislocation called nursemaid's elbow in children. All right, at the hand, we're going to have the patient extend their fingers and extend their hand. We're going to come and find this anatomical snuff box. The base of the anatomical snuff box is your scaphoid bone. And the scaphoid bone is important because if you fall on an outstretched hand, a lot of times this scaphoid bone will get injured, and your radial artery also runs right over the top of the scaphoid bone. And then we'll come to the ulna, we'll palpate down the ulna, have the patient radially deviate, and we'll roll off the end of this ulna right onto the triquetral bone. And that's an important bone because it is the site of attachment for the ulnar collateral ligament, and it is also can help you find the pisiform bone, which sits right on the palmar side of the triquetral bone. And then we're going to come up to the neck. So we're going to find the most prominent spinous process, palpate that, and then I'm going to put her in the patient in flexion or an extension. There's C7 because it didn't move, and then I'll move superiorly, extend, flex, and that's C6 because it disappeared during flexion and extension. And these vertebrae are important because it helps you orient yourself to the rest of the spine and to this region, and it's also the insertion site for the nuchal ligament. Then I'm going to come up to the base of the skull, roll right off the occipital bone, and the first vertebral prominence that I feel is going to be C2. And C2 is important because this is where the dens is located, and it articulates with C1 to form your atlantoaxial joint, which is a pivot joint, which allows for rotation of the head. And then we will move on to the facet joints. So locate the spinous processes and then just move laterally, and you're going to have to push deep, and you'll kind of feel those the bony end feel, and that is your facet joints. And these are important because it helps you find your cervical paraspinal muscles. And the facet joints are also important because they help hold all the vertebrae together. And then we'll just have you flip around. And we'll locate the first rib, so we'll find the manubrium and the clavicle, and we'll palpate just laterally to the manubrium and inferiorly to the clavicle. And the first rib is important because it's one of your true ribs, so it articulates with the sternum, and it is strengthened by your radiate ligaments. All right, we're gonna locate the 12th rib. I'm just gonna move your shirt up and palpate the soft tissues on the side. And then when you run into the bony protuberance, that's the 12th rib. This is important because it's an attachment site for the quadratus lumborum, and it's also one of 2 floating ribs. Next, we're gonna find the PSIS. So can I pull your shorts down a little bit? Okay. We're gonna come in and find the iliac crest, move posteriorly until we land on those the PSIS. It's important because it'll help you identify where S2 is, and it'll also help you find the sacral hiatus. From S2, we can count up and run into L5. L5 is important because it's the attachment site for your iliolumbar ligament, and it's also the common site for herniated discs and pain. We'll come back to the PSIS and move just inferiorly and in line with S4. We can palpate and feel the sacrum curve inward, curve medially, and that's the ILA, and that's important because it'll help you find the posterior sacroiliac ligament and the sacrotuberous ligament. Next, we're going to palpate for the ischial tuberosity. So if you come down and find the gluteal folds and push superiorly with your thumbs, you'll run into the ischial tuberosities. And those are important because that's where the hamstrings are attached, and it can help you locate your sciatic nerve in the sciatic notch. And finally, locating the greater tuberosity, I'm just going to palpate laterally with my palms, and the greater tuberosity will stick out into my palms. The greater trochanter, the greater trochanter is important because it's the attachment site for the glute medius and the glute minimus, and it is also the insertion site for the piriformis, which can be a site of pain in patients.